Welcome to the HQI Stopping Sepsis in Virginia Hospitals and Nursing Home Conference Call. My name is Jenny, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Deb Smith. Ms. Smith, you may begin.
Thank you, Jenny. And good morning, everybody. My name is Deb Smith, and I'm one of the improvement consultants working with the Virginia nursing homes for the Stopping Sepsis in Virginia Hospitals and Nursing Home Project. I want to thank everybody for taking time out of your schedules to attend this webinar. It's going to be very educational and presented by Dr. Susan Levy. Dr. Levy's presented other webinars for the Maryland Sepsis Project, so some of you may have already had the opportunity to hear her speak if you've attended any of the Maryland webinars, but this is the first time that we've had the pleasure of having Dr. Levy present on one of the Virginia webinars. So it's a really packed webinar agenda today, and I don't want to take any time away from Dr. Levy, so we're going to get right to it. At the end of this webinar, there should be some time to ask questions, but just in case, if you do have questions during the webinar, type them into chat, and then if we run out of time for questions or we have more questions than we have time for, we will get the answers to you from Dr. Levy. Next slide. So Dr. Susan Levy has been a medical director for over 25 years. She is the immediate past president of AMDA, which is the Society for Post-Acute and Long-Term Care Medicine, and she's currently serving on that executive committee. She's a medical director in Delaware and also does additional consulting work related to PALTC as well as for us here at HQI. Dr. Levy is a graduate of the University of Maryland School of Medicine. She's completed her internal medicine training at the Medical University of South Carolina in Charleston and her fellowship in geriatric medicine at Mount Sinai Medical Center in New York. She's board certified in internal medicine, geriatric medicine, hospice, and palliative care medicine, and she's been a certified medical director since 1996. So it's my extreme pleasure today to turn the floor over to Dr. Levy. Dr. Levy, the floor is yours. Dr. Levy, are you on chat? Or on mute?
Yep. Do you have me now?
I can hear you now.
Great. I always forget to hit that mute button or turn mute off. So anyway, real pleasure to be here today. Thanks a lot, Deb, and I hope you all can get a good review and go over some of these issues today. Basic review of some of the pathophysiology of sepsis, just in general, and then some special issues about how maybe are more unique in the nursing home, and really focus a little bit on communication with our practitioners as well as our medical directors, and about having some of the difficult conversations often with families and educating our families about sepsis in general. So some of the slides, there's a number of them. I'll try to go over just briefly. A lot of them are really informational for you. To really get started, I think what we all see is sepsis is this kind of overwhelming generalized response to an infection that initiates at some site where actually the rest of the body, normal tissues, actually become involved in this kind of systemic response that really is felt to be abnormal. We know it's important because it's a major cause of readmissions to the hospital as well as to transfers from nursing homes, and it often requires very highly intensive services and is very expensive to treat and often needs to be managed within an ICU setting. So again, some more of the gee whiz numbers about sepsis. Lots of cases, major cause of death in this country, leading causes we were talking about readmissions, and high mortality rates certainly increasing as the disease gets more, or the condition gets more serious, with the milder sepsis cases around 10 to 20%, as high as almost 80% in patients with frank septic shock. So we know that it's increasing in terms of it's being reported, although these are somewhat older studies. We think some of those reasons are because we do have a population that's aging, and age is one of the risk factors for sepsis, but also going not just with aging, but also with many of the other diseases and or medications, immunosuppression, which can increase the risk, the increased presence of drug-resistant organisms, which means that often if we are empirically treating an infection, we may get wrong and not be covering an infection from the beginning correctly. And also that we have a better recognition of what actually is sepsis and what is just a basic infection, really recognizing that systemic response. Okay, my slide won't go forward, so let's see. There we go. So some other facts in the literature. We know that with aging, there's the increased risk we've talked about. We know that mortality is higher in patients who are older. And we also know, I think what is particularly important, is that if we have sepsis from a pulmonary infection or a GI-associated infection, the mortality from those is certainly higher than from other sources of infection. We've talked a lot about, and it's really important today, about the readmission link. We know that patients who are hospitalized with sepsis have a significant readmission rate to the hospitals, and we know that that readmission rate is extremely expensive. So where CHF has a higher readmission rate, slightly higher readmission rate, we look at almost double the cost of readmissions and hospital care related to sepsis. So very expensive condition also to care for. Risk factors for the 30-day admission are also kind of listed that were identified in this study that was done in California back from 2009 to 2011. So in the elderly in particular, these are basically probably the same risk factors for infection in general, but why are they at higher risk? Because there are multiple comorbidities, there's general frailty, some of the medications that may be immunosuppressants that they use, the fact that they undergo more instrumentation or procedures, which increases their risk, the fact that they're hospitalized more often, which then exposes them more to the risk of other infections in hospital institutional settings, certain endocrine disorders, which are more common, particularly diabetes, and certainly the changes that we've said are associated with normal aging related to the aging of our immune system, and even the aging in our basic host defenses. Our basic mucosa that lines our various organ systems is not as robust as people age. Skin is much more fragile, and so the risk of damage and then subsequent infection is increased. We talked a little about the most common infections causing death, but certainly the most common infections leading to sepsis are urinary tract pneumonia, skin and soft tissue, and certainly GI. And they're the four areas that we're primarily wanting to be concerned about. Again, a brief kind of little schematic of the pathophysiology. On the top there is what the normal response should be, which is that, we're exposed to a bacterial pathogen. We have our normal host response that then localizes it, and then we have tissue healing and repair, sometimes with the assistance of an antibiotic. But there are also some things that we know that are infectious that can be treated with local measures. But in the case of somebody who becomes septic, we actually see where this response by the body and other organ systems really becomes overwhelming and develops this full sepsis syndrome where there's damage to other organs. And some of that organ damage is we notice changes in the respiratory system. These people develop leaky capillaries, leaky lungs, and so they'll not oxygenate as well, even not just with the pneumonia, but certainly with any type of sepsis situation. We know the metabolic changes that develop in a acidosis that develops, and certainly the hallmark of the elevated lactate levels. The impacts on the heart system, on the cardiovascular system, with hypotension and increased heart rate, dramatic impact often on the kidneys, resulting often in acute kidney injury, and effects on our blood and coagulation system that often can be seen as part of what's happening as someone's developing sepsis. Got to be a source, so we have to find the source of infection. And again, this whole issue of this abnormal response to the infection is the kind of key for what we're seeing. The real key is that this often happens very quickly, and so indeed our response to it needs to be rapid also. Okay. And some of this we've already kind of talked about the hypertension that occurs, the desaturation that occurs, and the reasons for some of that. The development is when it goes into full-blown, more severe sepsis of the coagulopathy that can occur. We also are certainly aware of, and that can cause certainly both clotting and bleeding. Time is tissue, and I think that's one of the keys to take away from all this is clearly the importance of, identifying these serious change early and intervening very early and intervening quickly. And sometimes I will say, particularly in our nursing homes, we tend to move a little more slowly than we probably should when patients have very serious acute changes in condition like this developing sepsis. This tissue is also important with onboarding of antibiotics. Although I know we'll talk about the link with antibiotic stewardship, it's also important that once we decide we think we are dealing with sepsis, that we need to get antibiotics on board quickly. And that it's not just any antibiotic, but it's also the right antibiotic. And so getting the right antibiotic on board, with every hour we lose survival time. So just like we talk about sometimes with trauma, the golden hour, and sometimes with sepsis, we also need to talk about how quickly we need to get on board and get the patient managed, both from their, if you will, cardiopulmonary status, but certainly from also getting actual treatment and antibiotic therapy on board. Okay. So I think most people hopefully are aware of that, back in February, there's been a lot of discussion over the, different terminology and different stages of sepsis. But back in February, one of the national organizations certainly proposed that we talked about sepsis and septic shock and recognizing a differentiation there, and a move away from the terminology of SIRS, S-I-R-S, the systemic inflammatory response syndrome, because it didn't seem to be as predictive of an actual underlying infection, and it wasn't necessarily always predictive of mortality. So we've kind of tightened some of the criteria here, and that's what this slide is meant to demonstrate. Some of the basic test results we often see in a patient who's septic, usually their white count will be high or low. We may see stress hypoglycemia, again, problems with coagulation, and we may even see symptoms of actual adrenal insufficiency related to this overwhelming condition. We look at the serum lactate level, and then we follow that over time. It's not diagnostic, but it certainly is a marker. And certainly once a patient's been diagnosed with sepsis and has an elevated lactate in a critical care setting, they will be, certainly monitoring that to see improvement and clearing of the lactate. And again, serum procalcitonin has sometimes been used, but it's probably not always as helpful. We've talked about this continuum from sepsis to septic shock. We want to intervene early. Certainly when the patient is developing symptoms of sepsis, and certainly before they develop frank septic shock, because we know not only is time important, but also the earlier we get the patient, the better their clinical outcomes. It's always important to use clinical judgment, although there's been more focus on trying to use sepsis bundles, which give us both time constraints and what actually should be done based on certain parameters. When pressure should be implemented, how quickly all of this done. But none of this really should be an exclusion of good clinical judgment in managing the patient. So overall goals are to make sure we maintain an adequate pressure to perfuse organs, that we get that urine output up to where it needs to be, and that we clear the lactate. And so the first answer in treatment is usually fluids. So let's talk a little bit about the nursing home population in general. We know who this is. We've got about 15,000 facilities in this country. We have a short stay population that often is there under their Medicare A benefit. So they're there for up to 100 days, but typically averages, which are declining, are running in the 20s, and some parts of the country even lower than that, for patients who are there for short stay interventions. And then our long stay population, who is generally there under, in terms of payment, under private payment or self-pay arrangements, who are most likely going to be there for an extended period of time or for the duration of their life. And then we have some differences as we have to think about issues related to the younger and the older population. Okay. All right, so this is just a quick review here of a study looking at nursing home residents. But I think what it's telling us is nothing surprising, is that if you're a patient for a nursing home and you're going to an emergency room and you are diagnosed with sepsis, most likely you're really sick when you get to the emergency room. You're more likely to be admitted to the ICU, and certainly your length of stay is going to be longer than a patient who's not from a nursing home. And again, the mortality rate is even higher for patients in nursing homes, probably related to the fact why is somebody in a nursing home having all those other risk factors that are present. Other things about sepsis in a nursing home, a lot of the symptoms that we look for can be blunted in nursing home residents, or may have other causes. And so when we look at fever, altered mental status, elevated respiratory rate, elevated heart rate, For lots of reasons that may be occurring, so we really need to be very good in our assessment skills. These patients frequently are colonized. They may be colonized with drug-resistant organisms. So we know, for example, if we culture a patient in a nursing home urine, we've got a 50-50 chance that that urine culture will be positive. So then we have to make a determination, is that really the source? Is that really the infection that's going on, or are those patients just colonized? We also have limited access to diagnostic testing, and turnaround times not as fast as in an emergency room or a hospital. Our step education and training, particularly on this topic, may be a little limited, and so we have some opportunities there also. We often don't have practitioners who can prescribe who are actually on site, so a lot of management can be done by phone, and even if they are on site, it may only be during regular working hours, unlike hospitals where you've got 24/7 coverage. And then also issues around delayed advanced care planning goals is that we often aren't addressing these issues timely, so we end up doing a lot of treatment before we really evaluated somebody's goals of therapy. Really basically the same there, but let's move in to talk a little bit about advanced care planning. I think the thing that's important, and that's kind of Osler's quote, is that infection and sepsis are not uncommon terminal events at the end of life. That does not mean they need to be treated. And so I think those discussions about end-of-life care, what to expect at the end of life, are really critical both for our patients, our families, as well as educating staff. And I came across this also, and I think this is really something important to think about. We've had a lot of focus on harm and errors in healthcare and how we want to, prevent that from happening. And I think if we start to think of failure to address advanced care planning as an error of omission that actually can create harm, that may be somewhat of a different approach, and maybe will get us a little more engaged and trying to recognize how important it is that we really reach out to our patients and families and understand what their wishes are, their values are, and where they are in their disease trajectory. And this did not show up so well, but it was basically a copy of the Virginia POLST form, and I'm sure you've all have seen that. But it does have sections. It is a guidance. It doesn't replace an advanced directive, but it really does allow some ability to transmit information across the continuum about patients' care and wishes. And it's a good framework to use for thinking about what types of care patients really want, whether they want aggressive care, whether they want comfort care only, or they want something, if you will, in between, in terms of whether they want resuscitation, whether they want a feeding tube. Those are all important discussions to have, ideally before, and frankly, hopefully even in the community, before patients develop serious illnesses. But it's an ongoing discussion that we need to have with patients and families as their conditions change and their disease trajectory changes. What is important is it's now going on to close to 2 years now, or into the second year, where practitioners can now get paid for having advanced care planning. There's a 99497 and a 99498. So Medicare even recognizes the importance of having these discussions and that they can be added to other visits that the individual is having. And so certainly make sure your practitioners are educated about their ability to bill for having these important discussions. So what do we do about sepsis in nursing homes? Well, a lot of the key in nursing homes isn't as much treatment, because we've identified these patients often are really sick and need very aggressive treatment. But maybe some nursing homes might be capable of providing, but many are not. And these are patients that really need to be in an emergency room for a very rapid assessment and then out into often into an intermediate care unit or even in the ICU because of the level of supervision and monitoring that they need. So it's really about prevention in the nursing home, and that starts with the basics of immunization, hand washing, good environmental cleaning, and what I always like to call the delining and deprescribing that can occur post-hospital stay, and make sure that we continue on those efforts that hopefully even got initiated during a preceding hospital stay. Also, using some of these tools and triggers that are out there will help us identify patients who are getting into trouble. So early recognition of changes in condition, and certainly changes in condition that might be related to infection. If we think the patient's at risk and we think that they have a serious infection, we may need to use early empiric antibiotic therapy, but it's also important with our principles of antibiotic stewardship to go back quickly and make sure that we reassess those regimens and stop antibiotics if we don't find any evidence of an infection. So I think that also the importance in nursing homes of having access to your certain key oral, high-potency oral as well as parenteral antibiotics is really key. And I think most or many nursing homes today really recognize the importance of having those available because I can get the patient treated quickly. Even if I ultimately end up making a decision to send the patient out, I can at least get some antibiotics on board quickly. And, of course, we're doing this all in keeping with the principles of antibiotic stewardship. Some of the other resources we need in our nursing homes. We need our nursing staff to really have top-notch assessment skills, to really be able to pick up these changes early and to do a thorough assessment because they're the front line and frequently the only one who's going to be then calling, ideally using an SBAR format, clinicians to then help make decisions about this patient's ongoing care and whether they're stable enough to still be managed within the facility. Because we're getting lots of pressure not to send patients to hospitals for conditions that can be managed in the nursing home, but likewise it's just as important if we have a condition develop where the patient needs a hospital level of care that we are very quick and we are timely in getting them transferred to the appropriate level of care. We are beginning to see more access to on-site physicians and nurse practitioners and PAs in nursing homes on at least a daily basis in many facilities, but certainly much more frequently than has been in the past. Again, developing some protocols in your facility, making sure that you're working with a lab that can give you good turnaround time. Can your staff get IVs in place as needed? Do you have the things on site that you need to be able to treat the patient, to give IV antibiotics and IV fluids? Rapid turnaround time also for your X-ray tests. And in some cases what we're seeing is the use of telemedicine, both with using emergency rooms or other types of on-site, off-site call centers to really help with the management of patients when they have a significant change in condition. We're going to introduce the QSOFA, which some of you may be familiar with. But it basically was developed, the initial SOFA score was developed more for ICU settings. But the QSOFA score, the quick score, if you will, is really to help address patients outside of the ICU. And we're going to look at that in a minute. I think we already commented on the SIRS terminology. So the quick SOFA score really has three things you need to be looking at. More than two, and you've got a good chance that this patient is particularly not going to do well. But we're looking for their systolic blood pressure less than 100, their mental status, and elevated respiratory rate, which, as we all know, we often don't measure well, but it is very critical in sick patients that we spend the time and really do count respiration. I would say that one of the flaws and problems in the nursing home setting, and in many other settings, is this whole issue about mental status. We don't often use consistent methods and tools to describe our residents. What I say is altered mental status may not be the same thing to you. We often don't describe their baseline mental status very well, so we can really determine whether the patient has changed or not. Just saying alert and oriented may not actually cut it. In nursing homes, we have the BIMS, which has been used, but it's a very crude test of cognition and often isn't very helpful for picking up some subtle changes. The CAM tool is useful, but right now in nursing homes, the CAM tool is embedded in the MDS and not necessarily used like it may be in acute care hospitals on a more regular daily basis or shift basis. And so there may be some consideration, particularly in high-risk patients who've had some cognitive problems or variation, of really thinking about educating your staff in the use of the CAM tool to help better describe and better monitor changes in mental status over time. So, again, we also do a poor job in managing and handing off mental status. We just send that patient out with a change in mental status, and we don't really describe the specifics of what it is. And so the receiving end often isn't really sure what they're working towards or what their baseline really should be. So both sides have some accountability there, both hospital to SNF and SNF back to hospital, and frankly SNF back to community or home care agencies can also be an issue. Another tool that's been developed is the Seeing Sepsis 100. It's the 100. And that basically uses this, temps over 100, heart rate's over 100, and their blood pressure is under 100, that those three things should be triggers for you that we need to be thinking sepsis. And that's just another example of that. Can't go back over them quickly. Know when to hold them and know when to move them out. I think that really is very key, and that requires that you have really good nursing staff really work on this kind of early recognition and assessment of these patients. One of the things I try to talk to some facilities about is actually just like we might do mock codes and practice other types of environmental disasters, do we actually practice drills when acute changes in condition? Identifying who gets communicated, who's in charge, how quickly we can do all this, where are the supplies, our phone lines to the practitioners, does that on-call system work well? And I think the last thing is that you have to ask yourself that if you think the patient's septic and you can't complete the full sepsis bundle in under 3 hours, that clearly is a patient that should be getting moved to a setting where they can. A little confusing is this, is we feel like we're being asked to do things that are all over the place. We're here talking about reducing sepsis, but we also have these issues around readmission reduction and antibiotic stewardship. So I'm just going to make a couple of comments about readmission and antibiotic stewardship and before we move on to the kind of next section. This is a report that came out from the Office of Inspector General a few years ago looking at the primary diagnosis and claims of all hospitalized Medicare nursing home residents in 2011. So again, it's several years old, but what this really shows you, if you look at these numbers, what they're saying is roughly almost two-thirds, 61% of recent patients go out from the nursing home to the hospital. And again, this includes nursing home patients going to the hospital. That roughly 61% of those are for these 15 categories of disease. And if you break that down further, you can see there that septicemia and pneumonia, then you have number 4 there, the UTI, and then aspiration pneumonia. If you add those figures up, almost, you come close to almost half of the numbers then really are related to infections of some sort. So this really is an area that warrants our attention also in terms of readmission reduction. And this may not show up so well, but what it's also trying to tell you is that those disorders, particularly sepsis and infectious disorders, are associated also with significant costs. So not only is it numbers, but it's also that those are expensive to certainly the healthcare system. And as we look more and more to bring value to healthcare, we've got to look at those areas where there's high cost, high prevalence, and maybe opportunities to improve value. Okay. Whoops, I went backwards. Okay. Let's talk a little bit more about readmissions. And I think I always like to go back to this article by Jennings. Again, it's a little bit older, but what it tells us, we focus on readmissions, and we have all these great pathways like the heart failure pathway. But what we realize is that the patients with heart failure who go back to the hospital, only 1 in 3 of those patients is going back for heart failure. They're going back for other reasons. And very commonly, that reason is an infection and or frank sepsis. So needing to drill down more about this, we've talked a little bit more about what's called the post-hospital syndrome. And basically the concept is somebody has an acute illness and other things happen to their other organ systems that put them at risk for having decline and deterioration that may then develop in their post-hospital stay and result in readmission. Some of the reasons for this we don't fully know, but certainly we know that one of the things that happens is that individuals seem to be at higher risk for infection in that post-hospital time period. So a very important time period. Talking about antibiotic stewardship, I think most of us have probably seen this. This is the CDC poster on antibiotic stewardship in nursing homes. Talks about the number of patients who are admitted, that we have a high number of patients who receive antibiotics, and yet when we really drill down in many of these cases, antibiotics weren't appropriate. So what we want to do is make sure that the patients that need antibiotics are patients who have serious infections, bacterial infections, that they get the antibiotics and get them timely, but make sure that we don't use antibiotics in patients who don't have a bacterial infection. And then again, going over the core elements, and I think that certainly is very important. And with the new rules of participation, the importance of us being able to roll out an antibiotic stewardship plan for our nursing homes are really, really important. So let's talk about some of the people who can help in the facilities. One should be your medical director. Ideally, someone who's certified. I am certified, so I kind of think that that's really important to do, mainly because it implies that I've had some additional training and education that includes management of infections and infection control in nursing homes. Certainly maybe not as much as definitely not as much as an infection control practitioner, but certainly some knowledge. and what the jobs are of the medical director. They should be having the facility with incorporating best practices into their policies and procedures, overseeing the medical staff and making sure that they're practicing appropriate guidelines, that they're responding appropriately when they're queried about changes in condition and timely, and that they're not abusing antibiotics or using them appropriately. And really should serve, the medical director should also serve as your clinical champion and really help you a lot in your SWAPI process in your facility. In terms of your practitioners, I mean, we're seeing a lot more nurse practitioners and physician assistants, but probably more nurse practitioners. I think the last figure is somewhere close to now almost 40% of nursing home bills that are submitted to Medicare are by nurse practitioners. I think we need to make sure that our practitioners know how to practice in this setting, and sometimes I think that's a problem. They come in and think it's either a community or it's a hospital, and they need to understand both the capabilities of the nursing home setting for what they want to be able to do. And they need to know what to do when they are called and how to respond. And the answer isn't always send them to the emergency room. They need to listen, and they need to listen to some of the recommendations from the nursing staff who's giving them, hopefully, that concise SBAR communication. Okay, and just kind of, we've changed the regulations, so I think it's now F841. If I look at the last version correctly, which really identifies what the medical director is supposed to do. And I talk about the CMD. It's a little bit of a plus, and it's a program that AMDA, offers. But there really are, of all the curriculum that's involved in the training program, infection control certainly is covered, as well as other areas that touch on what we're talking about in terms of transitions, quality management, integration of problem solving, system theory, and again, the oversight of the medical staff, and helping to be a leader and part of the solutions in a facility and not be part of the problem. Things for the medical director under the new rules of participation. They're supposed to be looking at consultant pharmacist consults. They're supposed to be president at QA&A or their designee. And again, the key there, though, is their involvement also in antibiotic stewardship and the definition of scope of services and needs, which certainly managing infections in the facility would be one of them. How can you better engage them? Well, the administrator and the director of nursing should meet with them regularly, set expectations, make sure that everybody's working not in parallel, but as a team. When you're having meetings at the hospital about maybe infection issues or any issues around readmission, they need to be engaged in part of those meetings. So all these things are certainly key to engaging your medical director. As well as your practitioners. I mean, people need feedback. And I know in some ways we're getting a little tired of all the report cards and that we seem to get, but it is useful information. It's important for people to know how they're performing based to their peers and their types of patients, and helps at least start the conversation. So I think that's very important. And above all, expect a culture of safety throughout your organization, including embracing your practitioners. So where do you focus? Where do you get started? Well, really, some of these issues are the same whether somebody's in a nursing home or not. I always say, just ask yourself the question, would you be surprised if this patient became septic during the next week when you're admitting a patient to a nursing home or you're doing a periodic reassessment? When you're rounding with patients, really engaging them and asking them if they feel better or worse. If they're worse, find out why. Because we know that often the signs and symptoms of infection and certainly signs and symptoms of sepsis can be very subtle in the beginning, but often in retrospect, we can go back and find where we may have been given an opportunity to intervene sooner. Who else? If they've got lines and instruments in, you've got to watch those very carefully. We've been great in nursing homes, I think, in getting Foley catheters out, probably much better than hospitals, thanks to probably OBRA. It's always been an area of focus for many years now in nursing homes, but again, we're still seeing some Foleys come in and trying to reevaluate the needs. So who else is at risk? Well, the sicker somebody was in the hospital, the higher their risk is probably of developing an infection. So if they were in the ICU during their prior hospital stay, that's a patient you really want to keep very close eye on. Patients who've had recently chemotherapy, and we know a lot of our postoperative patients who are also at risk, particularly if they had emergency high-risk dirty procedures. We know those are folks that were at risk in the hospital, that risk still continues. Who else? We know our diabetics, particularly if they're poorly controlled. Certain drugs. We know if they're having swallowing problems. We know if we're not staying on top of the wounds they may come with. All these are things that will tell us that the patients may be at higher risk. We know our dialysis patients are at high risk both for just infections in general and also infections at their access sites. So a number of things that should tell us who else is at risk. So just to briefly monitor about anticipate for sepsis prevention, some things that we should be looking at, just see if it can help us identify patient changes earlier. Other things we can be doing, are you doing morning stand-up? Are you doing it every day of the week? Are you doing at-risk rounds with your medical director when they're there? Are you engaging the practitioners when they're there about patients you're worried about? Are you trying to learn from previous patient issues? My question when we talk about transfers is always, okay, the look back and what we could have done or maybe identified sooner. Did we miss something? Could we have done something sooner? But certainly in patients who ultimately get admitted with sepsis, then the question I then ask them is, did we get them out of here quickly enough? Or did we sit on this patient too long? So again, it's the old, I call it like the Goldilocks stuff. You've got to get it just right. Not too much, not too little. It's got to be just right. So again, other strategies that all kind of link together. One of the things I did in one of my prior facilities is I expected that all first dose of antibiotics were given within an hour. If I made the decision that a patient infection needed to be treated, I should treat it now and not wait until 12 or 24 hours later when it comes in on the van. So I think looking at your timing of your antibiotic therapy in your building is important too. I think some of this didn't come through for some reason. But here's one. So we want to talk a little bit about, educating our patients and our families. And I think that really is key to all of our admissions. I mean, we're talking about the importance of patient-centered care, and how can we do that if we don't really engage our patients and our families. The slides that didn't show up actually talk a little bit about some studies that were done by the Sepsis Alliance, which is a not-for-profit organization that really is trying to do a lot to educate patients and families, and also to help support a lot of sepsis initiatives. And you'll see their logo sometimes on some of the, I think even some of the CDC information. What they have found out is that we've made improvement in strides in education, but we've got a long way to go. And compared to when they last did their survey, I think the survey within the last couple of years did demonstrate that now probably a little bit over half of people, if you ask them what sepsis is, will say they've heard of sepsis. That's pretty scary about a disease that's potentially can cause a death in this country. So we need to do a better job about recognition of sepsis among the lay public. When we look at how they got their information, the majority of those actually weren't getting it from medical professionals. They were getting it from media and or TV shows that they were watching. That's how they were educated about sepsis. And certainly, although we know that half of adults now know what sepsis is, probably only a third or less actually know what the common symptoms of sepsis are. So we need to do a lot more about educating our patients about sepsis, what signs and symptoms to look for. And we just really need to do a better job, because if we don't engage our patients and our families, we're not going to be successful in our preventive intervention. So I think that's key. These are some examples of different resources that are available to help educate residents and families, engaging them, various posters, various handouts. And these are things that are important if we're going to try to do more to engage them and help them partner with us. Very typically, if the patient knows something's not right and or the family recognizes that something's not right. It may be something minor. It may seem like an annoyance sometimes, but I think it is our job to stop and listen and try to see if we can explain what's happening. I also talk about sometimes it's watchful waiting after that. We know there's something going on. We just need to keep checking this patient frequently, watching vital signs, and see if we are potentially dealing with an infection or some other change in the condition, or whether it's going to resolve on its own. So again, the importance of educating. The other thing I want to remind people is that sepsis can be a real life changer. Not everyone recovers. I'm not even talking about patients who came from nursing homes, but patients who maybe went initially into the hospital. There are all sorts of post-sepsis issues that occur. including depression, including there can be some long-term cognitive problems. We know that some of these patients in their stays in the ICU basically develop PTSD. We know that there's post-critical care neuropathies that occur that may or may not resolve. And so a lot of times after a bout of serious sepsis, patients are going to have to deal with a lifelong change in their condition. And I think as nursing home practitioners, we need to be aware of that and be able to educate our patients that they may not go back to normal, and they may have to learn to live with some other disability. So I think that's certainly important. And again, here's some of the long-term effects that patients may see, and I think it's important to recognize these, that we're aware of these. And so as we're caring for these patients, as they come into the post-acute setting, we're able to educate and also kind of, work with them around that. And again, some more resources for where to get some more information. And I think with that, we can, I know I went quickly, I talked quickly, wrap things up and maybe have some discussion if there are some questions.
Thank you, Dr. Levy. This is Deb. That's a lot of information.
I got fast, I know.
And it's great information. And, of course, for everybody on the line, these slides are really good as a resource. So hopefully you've all been able to open up your the handout for today that was sent out with the invite. But if not, let me know because, like I said, there's a lot of good information on these slides. I really liked the anticipate and the Goldilocks, getting it just right. That's perfect, exactly. So, operator, can you let everybody know how they can get in queue to ask questions? We really have had a very silent chat today. There's nobody asking questions in chat, and I even put in a question myself about I wasn't sure how much of the telemed was being used for this, but nobody answered. So let's see if we can get some people asking questions on the line.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone.
So that's star and 1, everybody. Dr. Levy, I know one thing that I was wondering about myself was how many nursing homes are using SOFA? So maybe even if you just want to put it in chat, those that are out there, I kind of thought that was more of an acute care setting, but the nursing homes are using it also?
Well, it can certainly be used in the nursing home. I think that, we also want to be careful about, if you will, alert fatigue everywhere. And certainly hospitals have sometimes had that issue when they had the sepsis alert. But they've also been effective. I don't know specifically how many nursing homes are using it. I know we've been talking about it in some of the sessions in Maryland, but I can try to get some information if we know if anybody's been incorporating it. I mean, if you look at that or the 100, those really are things that you should be able to, more and more of the facilities are using electronic health records. You should be able to create some flags that would at least go to your alert list to make sure that you're picking up those changes in condition. Because I think that, I still sometimes, in looking back at charts, see where there was a low-grade temperature a day or two before. And so I think that, we need to look at your changing condition parameters that you call for, make sure that those fit our need to, have early recognition. But to be honest, I don't know how many facilities are using it, although it's a simple tool. You're right, it really was geared more towards help people outside of the ICU, but it can be adapted for any setting. Let's face it, frankly, many of our patients that we're seeing today, particularly our short-stay patients, often look like general med-surg patients. So we may need to start using some of the tools, like the CAM tool, which if you look at, I'm not saying all hospitals, but many hospitals use that as part of nursing shift-to-shift assessment, as part of their, their nursing assessment, and they do the CAM tool. Because early recognition of delirium often can help you intervene before things become way out of control. The patient's very agitated, and we know that with serious delirium, we have problems with increasing mortality and morbidity. Patients stay longer in the hospital. So recognizing subtle changes in mental status is also another important thing to be able to pick up.
Yeah.
But the actual numbers, no, I can't tell. The CAN tool I know is used, but it's in the MDS, which isn't necessarily all that helpful. Its location does not make it a kind of frontline, to me, doesn't make it really a frontline nursing tool, which is what it really is.
Right. So maybe everyone on the line, if you are using SOFA, I'm just curious myself to see how many are using it. We've been doing for the nursing homes, the 100, 100, 100. The hospitals actually have been getting some education on SOFA. So, I'm thinking maybe we should do a little more with that too. So anyone that's using it, please just type your name in chat that you're using it. Operator, do we have anybody in queue?
Yes, we have one question from Nancy Dean.
Hi, Nancy.
Hi, so this is Evelyn. I'm in the group sitting with Nancy.
Okay.
Coming to the 100 tool, is that heart rate greater than 100? Is that temperature greater than 100? And blood pressure less than 100? Is that what it means?
You got it. Very simple.
Okay, and those are more relevant to the flows, right? I mean, to do these assessments and kind of.
Yeah, I think it actually came out of one of the Midwest QIOs, if I'm not mistaken. And there actually are cards that you can give your nursing staff. And can we try to maybe get them the website? I don't know that I had that on there. But there's cards, there's even posters and handouts that you can use. My issue is that I think you should do something. Whether you like SOFA, whether you like 100, 100, 100. I mean, I think the issue is sepsis is a big enough problem. We need to get people's attention. One of the things I've always struggled with in working in a nursing home is that when a patient's gotten a fever and is really looking sick, we've got to stop what we're doing and address them quickly if we're going to be able to intervene and prevent that condition from deteriorating into something worse. Because I can't always predict who's going to be the one who can localize that infection and who's going to get frank sepsis. I mean, I know the risk factors. I mean, certainly being in a nursing home is one of those risk factors. But I know that when I identify that patient that starts to have those issues, I've got to really be able to act quickly and get them assessed quickly and get them treated quickly if treatment is appropriate, if that's what based on my assessment, if I really think this is an infection.
Right. And in that same slide, there were two other, I guess they were acronyms. One was AMDA, and the other one says Interact.
Right.
Can you elaborate a little bit on that?
Sure. AMDA is the American Medical Directors Association. It's also called, and the American Medical Directors Association, the Society for Post-Acute and Long-Term Care. There are tools that they have. There's something called Know It All When You Call, and then there's basically Know It All When You're Called. So the one set of cards is really to help people. This is for all changes of condition, not just infection. To tell you or help educate your staff what information they should gather before they call. And then the other is actually a tool for practitioners to try to help them know what they should be asking when a nurse calls them, for example, let's say with chest pain. So she gives the information, and then what do they need to ask back? And a lot of that is also about what are the resources and capabilities of the facility. So chest pain may not be a good one, but knowing what the facility is able to do and, diagnostically. Interact, I'm sorry, I thought pretty much, and I'm not remembering what the acronym stands for, but Interact is the tool that you've heard a lot about, readmission prevention, but it has a lot more tools around various disease management states, advanced care planning. There's a variety of different tools and if you actually just Google Interact, I think we're now up to Interact 4.0. You can certainly get a lot of the information is certainly free, and you can download a lot of the forms.
Thank you.
But that's been used a lot for the readmission interventions.
We have no further questions at this time.
So I am actually putting the Interact website up in chat. And I was looking for the Seeing Sepsis 100. I need to find that website. But that's actually the tools that HQI has been using for the nursing home.
Right.
So,
right.
you know, that one that you showed, the rapid diagnosis, the
right.
algorithm and things like that have been sent out to all the nursing homes.
Right.
However, you know, we can also share those files with the hospitals too.
Okay.
So I see, Centra, Joyce, thanks for typing in there that you all are moving to QSOFA. So any more questions for Dr. Levy while we have her on the line? Dr. Levy does consult with us, so certainly if there's any questions after this webinar, we can get them to her. She also has her email up there for you all if you want to take a chance to write that right now. Can you go to the next slide, Doc? Any other questions?
Oh. Oops. That's what happens when you put me in control.
Right. So this is just a picture of all the those of us that are working directly with the sepsis work. So Candy and Candy does the Maryland hospitals. I'm doing the Maryland nursing homes. I'm doing the Virginia nursing homes. And then we have subcontracted with VHHA, Betsy Cole, or actually it's Betsy Archer, and Wanda Clevenger. They are the consultants working with the hospitals on this project. So the next slide, please. And then if everybody realizes or not, but there is a larger nursing home improvement network that's kind of the umbrella for this work. And on that nursing home improvement network, Sheila McLean is the vice president, and leading that team of consultants that is Teresa Stella, Lisa Mark, and Allison Spangler. So just so you know, there's a number of people that you can call on for assistance with this. And the next slide, please. We do have some upcoming webinars. So the hospital, Stopping Sepsis in the Hospital webinar with Kathleen Bowman will be concentrating on those 3- and 6-hour bundles. That is July 6th from 11 a.m. to 12 noon. And then our next webinar it'll be a combined webinar again for the Stopping Sepsis in Hospitals and Nursing Homes, will be our quarterly data review call. And at that point, you know, we can share some of our successes and barriers that we've had to this work. That's July 25th, and that also is from 11 a.m. to 12 noon. Next slide, I think that was it. Yes. So you did get the evaluation, should have come up. So before everyone leaves us today, if you could fill out that evaluation. I want to thank you again, Dr. Levy. This was awesome, and this will be recorded, so we'll share the recording and the slides with everybody after we get that recording.
Okay.
Any last questions before we sign off and give you 3 minutes back in the day? Thank you.
Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.